everybody. Good evening and welcome to At America TV. My name is Jasmine. I'm one of the e-guys at America, and I would like to welcome all of our audience members joining us online tonight. We hope you all are doing well. So for those of you joining us tonight, welcome. At America is the U.S. Embassy's American Center, and our mission is to provide a space for young Indonesians to learn more about the United States. We have temporarily moved to a digital platform so you can still enjoy our events at home. So for tonight, we will be discussing Southeast Asia, pandemic, and lessons learned in low and middle income countries. But before we begin, as usual, I would like to tell you our social media quiz for tonight. So the question is, which Southeast Asian country has not recorded a single fatality from the COVID-19 pandemic? I repeat the question one more time. Which Southeast Asian country has not recorded a single fatality from the COVID-19 pandemic? So for those of you who would like to join our quiz, you can participate through our Facebook, Instagram, or YouTube by commenting on each platform. And also for those of you who have questions, you can also comment on each platform and our panelists will answer them during the event. So stay tuned until the end of the program and we will give live shout outs for those of you who answered the quiz correctly. And also don't forget to take a selfie and tag At America's Instagram account to share with everybody that you're having a great time with us tonight. All right, so to start the event, I would like to invite our moderator for tonight. Please give a warm welcome for Dr. Monica Nirmala, Fulbright alumni DRG MPH, Yayasan Alam Sehat Lestari Indonesia. Silakan, Dokter.
Thank you so much, Jasmine, for your kind introduction. Good evening, good morning, and good day, ladies and gentlemen from around the world. Welcome to this webinar. Thank you so much for finding time and coming to this exciting session. And big thanks to At America Cultural Center in Jakarta for hosting this important conversation. I'd like to say hi also to our audience who are streaming from social media channels, including at America, Aminef, Fulbright Indonesia, U.S. Mission to ASEAN, American Corners in Southeast Asia countries, and all Fulbrighters from around the world. This is an unprecedented time for all of us. We are now 7 months into the pandemic, and the global fight against COVID-19 is not over yet. We have seen successes in some countries, yet many countries are still struggling to flatten the curve. So tonight, we're going to learn from each other. And together with us, we have 4 public health experts from Vietnam, Thailand, the Philippines, and the United States of America. We're going to learn from their experiences of what works and what doesn't work in their countries, and see what we can apply in our own context. The whole session will take around 75 minutes. Each panelist will speak for about 5 to 7 minutes. Then we're gonna have a short Q&A session in between each presentation. And after all presentations, we're gonna have time for longer discussion at the end. And audience, you're welcome to post your questions at any time during this webinar on the comment section of At America live streaming channels, including Facebook, Instagram, Twitter, and YouTube. And don't forget to put your name, your location, and which panelist you address your question to. This event will be recorded, and the recording will be uploaded to At America website and social media platforms after this event. And presentation slides from Thailand and Vietnam will also be uploaded. Slides from the rest of the speakers, unfortunately, cannot be shared after this event. So before we dive in a moment, let us first hear some opening remarks by the U.S. ASEAN Chief of Mission, Melissa Brown. Sharjah Brown, the floor is yours.
Thank you so much. Well, first of all, do I get any points if I get the quiz right? No, I won't. Don't worry, anyone. I won't spoil the answer. But hello, everybody. I'm Melissa Brown. I'm the Sharjah, which is the acting ambassador here at the U.S. ASEAN mission in Jakarta. And I'm really happy to join you this evening for what promises to be a really important conversation about what we've learned so far in this fight against COVID-19 in the ASEAN region. And today we have a special focus on the lower and middle income countries. I really want to extend a warm welcome to members of the U.S. ASEAN Health Futures Alumni Network. We're calling it HFAN. So remember that. And they're joining us tonight. It's been launched just a few months ago. This is a new network of alumni of U.S. exchange programs. And it's connected more than 2,000, I think it's about 2,400 public health experts across the ASEAN region with each other and with US-based experts. This alumni network, HFAN, is just one of the ways that the US continues to partner with governments, with NGOs, with academia, with private sector across the region and globally to support our fight against COVID-19. I think we all feel like it's been a long time. This fight, 7 months, I don't even know how many months it's been, but it feels like it's been a really long time. But the reality is there's a long, hard struggle ahead of all of us. And I think until a vaccine or a really effective cure comes online, we're all going to need to tackle this unprecedented health challenge using a range of public health tools and really cooperating together. I really want to flag the focus tonight on low and middle income countries as the topic for tonight's discussion. Many of the best success stories, we all kind of wish we lived in New Zealand right now. Who doesn't wish they lived in New Zealand? It's one of these things. It's the wealthier countries like Singapore, like South Africa or South Korea, like New Zealand, and they really have relied on resource intensive solutions. And we know that's absolutely difficult to implement in larger or it's also out of touch for lower and middle income countries. So on the other hand, let's focus on where we've seen some real success. And I cover ASEAN day in and day out. There have been some really outstanding stories from within ASEAN of where lower and middle income countries in the ASEAN region have made some real gains against this virus. We know that public health experts across the region have learned a tremendous amount as they've advised, directed, and observed the national, subnational, and community level efforts to help keep people safe, healthy, all in face of this pandemic. So in that context, one of the most important things we can do is we can talk to each other and we can learn from each other. That's what we're doing here tonight. It's that type of exchange and that type of learning. Me, myself, and what I do day in and day out, I'm personally really looking forward to hearing from our panelists on what they've been doing and to hear their perspectives of what's gone on in the ASEAN region so far. I hope that this discussion is really going to spur us to continue to strengthen the knowledge networks that really are critical, because we've got to do this together. We're not going to do it apart. The one thing I want to underscore is I represent the United States, and the United States stands by you in this fight. We're going to continue to look for ways to support ASEAN as partners, shoulder to shoulder, fighting this crisis. We've provided $85 million in emergency health and humanitarian assistance to the ASEAN region through this COVID crisis. And that only adds to the $3.5 billion the United States has spent over the last 20 years covering health assistance, everything from TB to HIV to maternal and child health. I think when it comes to COVID, we've spent a lot of money investing in boosting testing capacity, supporting medical professionals, preventing the spread of the disease. But the United States isn't just the US government. The United States is also the US private sector. So they've really stepped up, and we've built on their innovation, that spirit of creativity, and they've provided humanitarian aid, they've provided medical supplies, and then a lot of the technological support. It's probably one of the reasons we're talking to each other right now. And we really remain committed to supporting these partnerships as we move forward. So I just want to close and offer a big thank you to all of our panelists. I know that you have a lot going on in your day jobs, and this is just something extra you're doing to contribute to the community. We really appreciate that. We know this is a really challenging and busy time for you. Thank you for caring about your community and really putting that first. And that community isn't just your individual countries, that's also the greater Southeast Asia. So with that, let me turn it back.
Thank you, Sharjah Brown, for your wonderful remarks. And next, we will hear from our first panelist, Dr. Pham Quang Thai from Vietnam. Dr. Thai was assigned to the Strategic Information Group of the National Steering Committee for COVID-19. He has been working on many aspects of Vietnam's response and is especially knowledgeable about how Vietnam has used testing and tracing. And those are the topics we're going to learn from him tonight. Dr. Thai, the floor is yours.
Thanks, Monica. So I would like to share my screen. Yep. So now it's a chance for me to talk about something that happened in Vietnam. We, like what you already said about, we have to go together. We have to learn from each other. And that things, we have to start from the beginning. We learn a lot from CDC, US CDC about EBS, about the event-based surveillance. We learn about how to hear from others, how to listen to the outbreak from different countries around, and try to prevent that before it can come to our country. And all of that knowledge keep enriched every day. So before I'm talking about the testing and contact tracing, I just sum up some of the information about Vietnam. So far, we have 381 cases, and 71% is imported case. The last community case is mid of April, and so far we don't have any community case. It is almost nearly 100 days. No community case in Vietnam. So why we can flatten that? We can somehow we can stop the community transmission. I think one of the most important is when you can see on this graph that the time of the different time we have passenger coming from outside bring COVID-19 to Vietnam. We learn from that because people come to the health facility and test, and they have turned out positive. And because of why we had that test available quite early, because we looking for the information from China. We see the sequence information of the gene of the virus. So we learn from that, and we start diagnosis the disease not by real-time RT-PCR, but sequencing. It is really costly, but it's work because we find case very early in January, and from that we use that information in order to make our own test kit, and using our own test kit, we find a case with a large scale of tests. The other thing also contribute to the succeed is the quarantine. Almost all of the people coming back from the high-risk area have to stay in quarantine center. And all those who contact with confirmed case also have to go to the quarantine center. And even we try to lock down the area, a big area, like a commune with more than 11,000 people in that commune have to lock down. And we feed them all. We make sure that none of them moving out of the commune, and all who have symptoms have to test, and even we test all of the community, like one commune in Hanoi. We lock down for 28 days, and we test 2 times at the beginning and at the end of the lockdown time. That's the reason why we are quite sure about no community transmission from the very early stage. Another thing that contributes to the success is a rapid response. I already mentioned about EBS active. We also have other things like a directive and decision on strengthening the measure to prevent and combat COVID-19. And we stick with that. We not change the strategy. The strategy is stick to that, and we just keep update about the virus information. And one other thing we just want to mention is we use evidence-based decision, and we not wait for WHO guideline. And clear leadership, because we have 23 different ministries in the government's committee, the national committee, that makes sure that every single ministry have to follow the guideline from the government and keep working on that on the same direction. And Ministry of Health play a critical role on that in order to make a recommendation. And we do the detection of case, isolating, contact tracing, surveillance, and all other things with a very, very early time point, as you can see in my presentation. It's very early to start that. Why we can start that early? Because we find from the flight coming back to Vietnam, there's a lot of flight have COVID-19 patients. That's the reason why at middle of March, we start to quarantine own flight that come to Vietnam. Don't care about the country. And we test all of the passengers. And as you can see, so far we have more than 80 or maybe 90 flight that have COVID-19 patients. And that's the reason why all of the measurement so far we find is correct. And recently, just the day before yesterday, we have one flight coming back from outside, from a foreign country, carry 8 passengers with COVID-19 positive, and all of them stay time in quarantine. All of the passengers in the flight. Why we can do that? Because we know if we're not doing that, we will fail, because we don't have enough medical equipment. We don't have enough ventilation, ICU. All of that is resources that we have, scarce resources. So only thing that we can move out is quarantine and testing. And at the beginning, we have only 4 institutes that can do the test, the real-time RT-PCR. But at the end of April, we have 120 different lab facilities that can run the test. And so far, we have done 400,000 tests. It means for one positive case, it costs us more around 1,000 tests. It's a lot because we try to find almost everyone. Don't miss anyone. And for contact tracing, technology really help. We use the technology to find a case. From the case, we find the one who have contact with the case, and not compare with other country. The other country only focus on the one who have symptom. In Vietnam, we focus on everyone that have a contact. So sometimes with one case, we have something like 200 contacts, because we look back almost 14 days from the time they can have contact. So we have contact round 1, we have contact round 2, and we even ask contact round 3 and contact round 4, stay home and waiting for the result from the contact round 1. If the contact from round 1, the one have close contact with the case, turn out positive, then all of the other round will have to consider as the one who have contact with the positive one and have to test all. And all of them have to stay in a health facility for 14 days and have at least 2 times of testing. That is the reason why we have used a lot of tests even from the beginning. But at the beginning it costs a lot. But after we can control the situation. Every day now we have about only 1,000, 2,000 tests a day. It's not much, because compared to that much of population, we have 90 million of people. We don't have to use too much of tests, but we focus the test to the one who need the test. So the lesson learned from our country is we have to base on our cell capacity. Testing. We have to build our own test kit. We have to be certain about what we can do. We have a very strong surveillance network with more than 12,000 of health facilities that can help to help quarantine, help provide information, help finding the contact, and so on. And one other thing also we want to say is to keep learning. Every day we learn some new thing from others. Every day we learn new thing from outside about COVID-19, about other diseases that relate to, and that's why we can keep moving forward. And one most important is transparency. There is no hidden from the government about case, because if we not show the case, we cannot ask other people to go to quarantine, cannot ask people to follow the guideline from the government and so on. Transparency is very important, and health education using that transparency. So that is the experience from our country. I'm welcome to all of your questions. Thank you.
Thank you, Dr. Thai. Very remarkable progress from Vietnam. I have one question for you. So you said in the beginning, Vietnam only had 4 labs that can test the patients, and now you have 120. I'm curious, how do you ramp up your testing capacity in a relatively short amount of time? Do you have all the labs, technician, and networks ready even before the pandemic hits?
Actually, the real-time RT-PCR machine is not difficult to get. We have the system for Japanese encephalitis. We have system for influenza. We have system for many different diseases. The only thing is training. So when we have 4 reference labs from 4 main institutes for hygiene and epidemiology or Pasteur institutes, from that 4 institutes, we do the training for different labs, and we give them the certificate when they can perform the test correctly, accurately, and we also do checking, regular checking. For example, if they can find a positive case, they need to send the sample to 4 reference lab in order to retest and to make sure that the test is correct. And we also send sample back to them, asking them to test if they can find among those samples which one is positive, which one negative, and we can see how accuracy they have. And that procedure is reduced almost every month to make sure that all of their procedure is correct. And we also send supportive supervision to all that health facility just to make sure that they can perform the test correctly. And I think the test kit from Vietnam is good because that one already sent to UK, sent to WHO, to have the check, have a calibration from them, and they all send a very positive feedback for our test kit. And I think it's good. Huh?
Yeah, very good. Thank you so much. We will continue the discussion later, Dr. Thai. And just a reminder to you audience, feel free to ask questions in the comments section. And don't forget to put your name, your location, and which panelist you address your question to. We're moving to our second panelist, Dr. Ronald Lau from the Philippines. So Dr. Ron is the Chief of the Preparedness Division, Health Emergency Management Bureau of the Philippine Department of Health. As a senior medical officer and public health practitioner, his work is focused on health emergency and disaster risk management at the national level. Currently, he performs policy, planning, and operation functions in the COVID-19 response of the Philippines. Tonight, we're going to hear from him about the Philippines' social distancing and lockdown policies. Please welcome Dr. Ron.
Good morning, afternoon, evening to all listeners and viewers from around the world. I'm both honored and happy to be sharing the Philippine COVID-19 experience. Thanks to America, the U.S. Embassy, and of course the U.S. for putting this together and for this great opportunity to share. I'm going to be talking about the Philippine case study on doing early lockdown to be able to slow down transmission and shore up the capacities of our health system. So I think there's a technical glitch. So can I request for my slides to be presented by the organizer? Okay, I'm sorry about that. So I'm going to be sharing our Philippine case study on doing early lockdown to be able to slow down transmission and shore up the capacities of our health system. Next slide. As you know, the Philippines is a highly populous, low middle income country, a democracy that features fun, religious, and peace-loving Filipinos. A great majority are educated, talented, and hardworking professionals working abroad. The Philippines is known for her many beautiful islands and, unfortunately, the different emergencies that affect its people. Health threats would often challenge the limits of our health system, but as the world will agree, of course, COVID-19 is way more different. Next slide. Okay, back in December 2019, when cases in China were reported, to January and February of this year, when the Philippines had its first few imported cases, the Philippines activated its response plan by implementing strict screening, travel bans, surveillance, preparing points of entry, laboratories and hospitals for possible cases, and activation of the interagency task force, which facilitated the repatriation of overseas Filipinos. In March, when the first case of local transmission was reported, and as soon as cases started to increase, lockdown was instituted to slow down transmission. After all, our country could not afford to have an overwhelmed health system at the outset of the pandemic. Next slide. After a careful deliberation of public health, economic, and social considerations, a state of public health emergency, then a state of calamity was declared. The lockdown focused on Metro Manila and Luzon because these are areas at very high risk of transmission. It was gradually implemented in a phased approach. Overall, the lockdown lasted for 3 months, after which some modifications were made in terms of the quarantine. So basically, the lockdown consisted of class suspension, prohibition of mass gatherings, suspension of public transport, work from home. Only essential establishments were allowed to open, and only essential workers could move around. There was also restriction of land, air, and sea travel. Essentially, the lockdown was about strict social distancing, observance of health protocols, and enhancing capacity of our health system to be able to do detection, isolation, testing, and treatment. Next slide. After having 3 months of hard lockdown, relative success was achieved. Though cases were still going up, the case doubling time significantly increased. Deaths were somehow reduced and recoveries went up. More importantly, health system capacity in terms of tracing, testing, isolation, quarantine, and treatment considerably improved. Next slide. To mitigate the economic impacts, quarantine restrictions were eased and modifications were done on the condition that public health standards will have to be followed. So these are about social distancing, wearing of masks, sanitation, hygiene measures. So they have to be strictly observed by with the people. So that's the only condition. Next slide, please. From achieving some success from the early lockdown, the situation, however, quickly changed. As of today, within Southeast Asia, the Philippines is top 2 in terms of number of cases. There are 61,266 cumulative number of cases, 1,643 deaths, and 21,440 recoveries. Currently, the trend of cases is increasing because of various factors. And there are indications that the health system can still cope, but of course with much difficulty. Next slide, please. So thus far in our response, we have learned the following. First, decisive leadership based on science and evidence can make or break the response. Strong political will is essential, but sound strategies that are coming from the public health and scientific community should influence the decisions. Policies also need to be calibrated to adapt to the fluid situation. Second, whole of society involvement is necessary to address several concerns: public health, economic, and social. So both national and bottom-up approaches are proving to be helpful. Public and private sectors, the academe, civil society, international partners from discipline that are different are working together. And thirdly, clear, effective, and transparent communication can reduce public anxiety, build trust, and help mobilize people. So the lockdown is only one among many strategies here. And we really believe that people's personal healthy behavior should be the key. Next slide, please. So these are challenges that we are experiencing. First, there are some limitations or shortcomings in preparedness. COVID-19 is an unprecedented event. So Philippines is used to managing different disasters and even other epidemics, but this biological hazard with its scale and magnitude is really very challenging. So secondly, as a low middle income country, resources in terms of human, logistics, the needed supplies, the infrastructure and technology, if only sufficient, of course, in a big populous country can go a long way. So thirdly, we always go back to how the health system was before COVID-19. So the devolved setup and the fragmented the health system, the high levels of health inequities between rich poor, so social determinants of health, especially poverty, and other health threats that come along are very critical to address as well on top of our response to this COVID-19 pandemic. So next slide, please. So in summary, the Philippines had made significant, some partial relative success in doing the early lockdown by being able to show significant decline in transmission and more importantly, improvement of our health system capacity. However, with the current trend of increasing cases after the economy, which is also necessary, the fight is far from over. Observance of minimum health standards, we understand more than the lockdown is necessary. Health system capacity, although much improved now, is becoming more challenged day by day. So we conclude that in the present situation, a combination of social distancing measures and risk communication and behavioral interventions should still be important strategies. But aside from this, the Philippines has to double up in improving tracing, testing, isolation, and treatment strategies to change the course of the pandemic, at least in the Philippines. So thank you for listening and looking forward to the discussion and hope to learn about the good practices of our friends in the region. Thank you.
Thank you so much, Dr. Ron. So I have one question for you. So in your presentation, you mentioned about your devolved health system in the Philippines, and you mentioned that as a challenge in your country in addressing COVID-19. And what do you learn from that? Like how do you think Philippines should move forward in terms of maybe improving your health system, especially in facing other similar threats in the future?
So first, that's right. So we have to strengthen the existing health system. So the devolved structure is really a big challenge, but we have to work well with the local government units because in our setup, they are the ones primarily responsible in managing that. So all of the assistants, they're basically ramping up their capacities to do everything that's possible to help that out. But there should be clear-cut delineation in terms of what local government should do. So I think more bottom-up approaches should be necessary now because all of the policies have already been developed. So I think that's the key role of the national government. So working well with local government units, but in the context of strengthening health system, I think that's the most important thing, how to strengthen local health systems to address different health threats, especially pandemics of this magnitude. So that's helping out in terms of technical assistance and even resources, which can be far constrained, especially in those local governments with the high poverty rates. So that's it. Thank you for your question.
Thank you, Dr. Ron. We'll continue our discussion at the end. So before moving on to the next speaker, I have one announcement. So for those of you professionals who are actively fighting against COVID in your respective sector and would like to continue the conversation with other professionals in Southeast Asia and other developing countries on best practices and lessons learned in dealing with the pandemic, please join us and fill the form at bit.ly/US ASEAN Health Future. You can find the link on the comment section later. We'll move on to our third speaker. Our third speaker is Dr. Sharatdao Bunti from Thailand. Dr. Sharatdao is the Medical Director of Global Health Protection Division at CDC in Thailand. She has been involved with Thailand's COVID-19 response since the beginning. She used to work at the Thai Ministry of Public Health on infection prevention and control, as well as developing the Emergency Operations Center with which she now works together. She's going to share the topic of isolation, quarantine, and public behavior change in Thailand. Dr. Sharatdao, the floor is yours.
Can you see my slides? Okay. Okay.
Yeah, we can.
Thank you for a nice introduction, Dr. Monica. Just minor correction that I'm not yet a director. I'm the medical officer of the Global Health Division of Global Health Protection at CDC Thailand. And thank you, the At America, for the opportunity for inviting me to share the experience on the Thailand COVID-19 response for the success and lesson learned that we have on the topics of encouraging and supporting public behavioral change and isolation and quarantine. So I will speak on behalf of the Ministry of Public Health. Before going to the COVID-19 response, I'm just giving you the overview of Thailand. So it's a small country in Southeast Asia, and we have a population of around 66 million. And Thailand is one of having one of the best healthcare system in the world, I believe. And the majority of the Thai citizens are covered under the Universal Health Coverage Program, and which means that everybody can access to healthcare for free of charge. And we have a diverse and complex healthcare system, both the private and the public, and also some other labor care access. And we have national laws that can regulate and regulation that can impact the public health emergency management. And also it will help facilitate detection, control, and reporting the communicable diseases. And Thailand is a high risk for case importation. Why? Because one of our economic gain from tourism. And each year we have 35 million of tourists coming to Thailand. And then 1/3 of those, which is around 10 million, are Chinese. tourists that's coming to Thailand per year. So Thailand is quite famous for Chinese people. And this is also why the early imported cases of COVID-19 in Thailand are imported cases, because people coming all around the world for tourism in Thailand. And they start testing, isolation, and contact tracing on those cases. So this is the Thailand COVID-19 timeline and also the control measure that the government of Thailand put in place to control the spreading of the disease. We're starting at the early December that unusual pneumonia detected in Wuhan, in China. So quickly after that, the Thai Department of Disease Control under the Ministry of Public Health noticed that this is an unusual event, because we, in the past 10 to 20 years, we experienced many of the emerging infectious diseases before. So we think that this is maybe another one that's coming. So quickly, they activated the Public Health Emergency Operations Center to follow the situation closely, and followed by first imported case, as we expected, because the season for the tourists, December, January is a high tourist season. So we have the first case, which is I think the woman from China, and then in the end of January we have the first domestic the Thai case in country, and after that, why other country the disease has spreading and on the rise of the cases in many countries around Thailand and also in other parts of the world. So in early to mid-March, so we're trying to control the spreading of the disease by doing the disease investigation, contact tracing, and put a lot of control measures on that. But again, so we have the super spreader. Like we before that, we had the super spreader in Korea, and then so now here in Thailand, from the famous boxing stadium. So Thai boxing is a very famous sport, and a lot of people from many of the provinces around the world is coming to this event. And then so they went back to their hometown, and so another cluster pop up in many provinces of Thailand. So the cases are on the rise. So the government put in place the control measure by declare the emergency decree on the public administration in the emergency situation in late March. And then to limit the movement of the people in April 2nd, so we start the curfew. But it's not a 24 hours curfew, it's only like about 6 hours. So people still can go into work, move and have a movement, but a limited time. But following 2 days after that, so we locked out the country, or the airports were closed for the commercial flight. For a month later, it seemed to work. So the case is going down, and we're starting to release the restriction by phases, step by step, phase 1 to phase 5, currently and in about 2 weeks duration. So people start moving around, but some restriction because the emergency decree is still there. And the government is thinking about reopening Thailand by opening the airport for a commercial flight in September, but that's still some time to go and a lot of consideration to put in place for that. And here is the epidemic curve from the beginning to the situation currently. So you see that we have very few cases at the beginning. And, when we, as I mentioned, that when we heard that there's unusual pneumonia cases in China, so then the Ministry of Public Health quickly starts screening at the of all the travelers coming to Thailand at their all ports of entries, which mean the airport, the seaport, and the land, POE, and then activated the EOC quickly afterward to put the people put the control measure. And then after that, so there's many countries that are affected by COVID-19. So the WHO have to declare it's at the public health emergency of international concern. And after that, there's still some cases in Thailand. So, and we cannot control some of the people because as the public officer, we don't have any authority to isolate or, we don't have the law enforcement power with the public health officer. So the Ministry of Public Health decided to announced that the COVID-19 is a dangerous disease under the Communicable Disease Act. So make more power or giving more authority to the public health officer to control the situation. But again, this is still uncontrolled because of the boxing stadium. There's a large outbreak occur. So what do we do? So we declare the emergency decree to stop the reduce or stop the movement of the people and lock down the country in April, because in April is a Thailand New Year. So there will be a lot of movement. So then this measure were put in place. So then the case is going down. And also not just the policy driven, but we also in combination with other intervention they put in place, like social distancing, wearing face masks, washing your hands frequently, those kind of things to that Dr. Law and Dr. Thai already mentioned in the previous presentation. I wouldn't repeating that. So this is where we are now in Thailand as of July 15, which is yesterday. We have the total case of 3,232 with no new domestic case for 51 days. So the curve is flattened. And the new cases that we have is only the one that imported case, which detected in the state quarantine. So we are in the good shape, and also the still continue the screening at the port of entry. So you see the number of people that we still screening, even though the airport is closed for the commercial flight. But there are some people that wanted to come back to Thailand with permission from the Ministry of Foreign Affairs. So
Dr. Karatna, would you mind wrapping up your presentation?
Sure. And from the the early phase of the outbreak, so to the local transmission, the more and more. So we put a lot of community mitigation intervention, like school closure, bar, restaurant, and also using the public health emergency laws to decrease the disease transmission, and also expanding the testing site and isolation the patient, quarantine of contacts. And one of the success that I think that is a highlight of this response would be the communication that would help changing the behavior of the people in Thailand. We have the spokesperson, several spokesperson that will talk to the public and the media regularly, and ad hoc, and sometimes that we have an urgent issue, will be the first and will be the right, and also transparent with them. So building the trust with the community, building the trust with the public, use all kinds of medias to promote the intervention that we have, especially the social medias, and combat with the fake news that happen along the way. And also face mask is one of the success in Thailand, because we experience some other pre-existing culture that wearing the face all the time, because we have occasionally pollution every year. So people are aware of face is protecting your health from the threat. And isolation and quarantine, we have quarantine guidelines that clearly identify who would be isolation, who would be quarantine, and how long they have to be in quarantine, and where would they be. So either home quarantine, local quarantine, or state quarantine, and what procedure will be taken in while they're in quarantine, what data collection they have to provide, what lab testing, how many times that they do, and tracking system of their health. And also we have the community support strongly from the community leaders that will help communicate with their people in the community. And also we have the health volunteer that can go and check out with the people that in quarantine if they're okay, and we have volunteer to help bringing food, providing support if they need. So then the quarantine people wouldn't be alone at home or anything. So we use a community support as a way to help them. So I think this would be my last slide. Thinking about reopening Thailand, excuse me. So as the curve is flattening for about 51 days, So we think about the phasing. We already done that, and the emergency decree will end in July 31st, and with the hope that the government will not extend it. So the people from outside Thailand who is Thai or other who that have to be allowed by the MFA to come into Thailand. So all of those have to be in the state quarantine and follow the guidelines strictly. And next step, opening for tourism, I think that's a long way to go. So we, because of the countries around in this region, they're still up and down in the cases, and the second wave or third wave is coming. And also Thailand, we have to prepare for the second wave if that will come when we starting to, put on the relaxation. And also people have to get used to with their new way of living. So we call it a new normal, like trying to stay home, working from home, using audio conference like we're doing right now in the ways of communication, and washing your hand, keeping you healthy, eating fresh food, and also using your own utility, not mixing with other people, and try to be, distant from other people, like 6 feet away. And every places in shopping mall and restaurant, they need to have the material or supply to for the cleaning, like the alcohol gel. And also we have the application that everyone that going into places have to download it and check in and check out. So then if there's some case occur, so we know where they're from and where they went to. So then that will helping with the contact tracing. So that would be the end of my slide, and I'm happy to take any question that you have.
Thank you, Dr. Sharat Dao. Very informative presentation. I will keep the questions for later, for our discussion later. And we're going to move on to the fourth speaker. But before that, I'm going to remind our audience, you're welcome to ask questions in the comment section. And don't forget to put your name, your location, and which panelist you address your question to. So our final speaker is Dr. Bhakti Hansoti from the United States of America. Dr. Bhakti is an associate professor in emergency medicine and international health at Johns Hopkins University. She's also an associate director for the Johns Hopkins Center for Global Health. During the pandemic, Dr. Bhakti has been both on the clinical front lines as a physician and actively involved in Johns Hopkins' ongoing virtual seminar series on strategies to support the COVID-19 response in low and middle income countries. I'm your loyal viewer, Dr. Bhakti. Please welcome.
Thank you, Nirmala, Dr. Nirmala. Is that the correct slide that's sharing? I can't tell.
Yeah, it's
perfect. So in the short time that we have together today, I can at best provide a cautionary tale. What you've heard with all of our speakers is that the pandemic has evolved, as have the public health recommendations. And so too have the clinical management recommendations also. But this is a cautionary tale because as the audience of public health leaders, professionals, clinical professionals, as citizens, it is really confusing to know what is true and what is not. And so what I want to do is guide you through some of the examples of clinical management guidelines and how they've changed, and hopefully use this as a venue to kind of just increase the awareness of clinical management moving forward. So globally, 13.3 million people, which is a lot of people, have had COVID-19. 7.4 million have recovered, which means we have a lot of data on those who have survived, but there have been nearly 600,000 deaths, right? And we know some things about this illness. We know that fever and cough, shortness of breath, hypoxia are the hallmarks of the illness. We know that symptoms start and time to diagnosis can take 4 to 5 days. We also know at 5 to 10 days, some people get very sick and develop a phenomenon called the cytokine storm, which leads to secondary organ dysfunction and illness. But most people with COVID-19 have uncomplicated or mild illness. 14% of us need hospitalization. So these are patients that need extra oxygen support, or have some evidence of end organ dysfunction. 5% need ICU care, so they're in high flow nasal cannula or intubated, require mechanical ventilation. They need a machine to help them breathe. And these severe cases of COVID-19 are complicated by acute respiratory distress syndrome, which is a pathology of the lungs, by sepsis and septic shock, which is infection that causes your blood pressure to go low, your temperature to go high, your heart rate to go high. And then those cause secondary multi-organ dysfunction. So then your kidneys and your heart and your brain become affected. Managing COVID-19 has been the focus of my work and of the COVID seminar series for Johns Hopkins for the last 4 months. And what I can tell you, it's a challenge. It's so difficult to put together cohesive, strong guidelines when the data is so shaky. So traditionally, right, as a physician, I have spent most of my life studying to be a doctor, reading textbooks, understanding diseases that haven't really changed. Yet with COVID-19, we are making decisions on how to manage patients based on a handful of cases. And those cases, which are single center, are subject to resource biases, cultural biases, practice biases, and may not fully apply to broader populations. One case series that really changed the way we thought was by Gattinoni in Italy, right? So he talked about these two different lung phenotypes, and clinicians started understanding that not every person with hypoxia has ARDS or vice versa. And that changed how we practice medicine. But other cases have led to touting miracle therapeutic cures, which have had consequences. Just yesterday in the American Medical Association morning rounds, a study says, and this is sensationalization, right? More than half of patients with COVID-19 have heart damage. Now, I've had COVID-19. I spent 3 weeks on home oxygen therapy. My husband was admitted to the ICU. So we had severe COVID. And it stopped, and I was really worried. And then I looked at the article, and what I noticed was that in one hospital where a number of patients had severe illness who had markers of heart disease, when they did an echocardiogram, that was positive for heart damage. That doesn't mean all COVID-19 patients have heart damage. My mother texted me that thing on the right, which is 1.5 gram of aspirin and lemon juice and honey will cure COVID-19. It was spread through wildfire in India. And many of my relatives I know are taking this. It is just not true. FYI, false news. And then there is commercial marketing too. So Fabiflu, which is actually an approved over-the-counter medicine for flu-like illness, has now been rebranded in India to treat mild to moderate cases of COVID-19. The challenges of all of these missed data is that people don't know what to believe. But there are other consequences too. So a tweet by the President of the United States of America talked about hydroxychloroquine and azithromycin. People were like, great, we have a savior drug. This drug is available. We know it's safe. We all need to use it. People stockpiled, right? Then came out the study on the bottom, which is a Lancet study that said, actually, looking at the Surgisphere database of 15,000 patients, hydroxychloroquine significantly increased the risk of fatal arrhythmias. So what happened? The data stopped, the clinical trial stopped. So we're in this position now where we actually don't know if hydroxychloroquine is effective or not, who it should be used in, which patients it's effective in, and whether this is a curative medication strategy or if it's potentially dangerous to our population. So there's consequences not only at the public level, but also at the health professional level. Some of the data is fake news, right? So this Lancet article was retracted because there was concerns about the integrity of the database in which the assumptions were made. However, some of it is just information overload. So early on in the pandemic, right, so January, February, we had a handful of publications talking about COVID-19. As of April, 9,435 articles. As of today, that number's definitely north of 12,000 articles. I can't keep up. There's numerous resources to try and keep up, but it's really difficult to interpret that data and understand what is relevant and what is not. What we call is the coronavirus infodemic, right? Multiple sources of information, multiple venues for information. My recommendations are that you look for reliable sources, favor print media. If there's a claim about the virus, go back to the research and read it carefully. If something sounds fake, then don't engage. And before you tweet, before you share, before you forward to your family, double check the facts. The WHO put together this phenomenal site, which is called the Mythbusters for COVID-19, which provide public health professionals with tools and strategies to combat some of the common myths. But there is also a number of clinical myths too. So I stated a few on the slide. Early intubation was a myth. COVID-19 leads to ARDS. You need high levels of sedation. People need something called PEEP, positive and expiratory pressure with hypoxia. The steroids are needed now for all patients. High dose anticoagulation prevents strokes in COVID-19. And the one I mentioned earlier, 50% of COVID-19 patients have heart damage. Now, none of these things per se are actually false, but they don't apply to the whole population. COVID-19 patients are extremely heterogeneous, which means that each individual has a different underlying phenotype, pathophysiology. And what I want leaders here to take away is that going back to basics, I think is the key here. As data evolves, as evidence-based practice comes to light, we have to look at that data and interpret it. But good medicine based on good history, good exam, good diagnostic skills is going to be more effective than a Hail Mary miracle cure. There is a number of therapeutic drugs under investigation, but there is also existing drugs for certain pre-known conditions that are shown to benefit COVID-19 patients. So again, going back to what we know may be the fundamental strategy to supporting COVID-19. I know I went over and I apologize, but I'll take any questions.
Thank you so much for your insights, Dr. Bhakti. I have one question for you. So a lot of people are now worried and just exhausted and looking for a clear-cut and steady information on COVID-19. So how do you communicate uncertainties and changing evidence with the public?
So when it comes to sources of information, I would stick to reputable sources that you're aware of. So for example, the WHO is a great reputable source. Johns Hopkins, for the clinicians, we have actually a huge data center whose job is to interpret all the new evidence and put it into context and put out briefs on the changing evidence. When it comes to communication with the public, I think what we need to do is address why it's changing. So when I give lectures or talks, people are like, who do I trust and why are they changing their minds? It just shows they don't know what they're doing. And the truth is, it's not that the public health professionals don't know what they're doing. They're reacting to evolving data. So I think if public health professionals can make it clearer why policies are changing, why guidelines are changing, why this transition is occurring, I think you'll get better buy-in from the public.
Great. Thank you so much. Before we move on, just a reminder for the audience. So as a follow-up to the webinar tonight, for those of you professionals who would like to continue this conversation on best practices and lessons learned in Southeast Asia and other developing countries, please join us and fill the form at bit.ly/US ASEAN Health Future, and you can find the link on the comment section. Now we're moving on to the Q&A session, and I'll invite all speakers to actually unmute yourselves. I have some questions from the audience, so speakers feel free to jump in, give comments, or ask further questions to other speakers. My first question goes to Dr. Sharat Dao. This is a question from Thane Min from Myanmar. So, as a popular destination for tourism and regional migrant workers, how will Thailand cope economically with the new normal if there is no effective vaccination available for the public throughout the year 2021?
Thank you for the question. I think, and that is a very good question because, as I mentioned, that one of the Thailand economic based on tourism, and because of the shutdown of the country and no other tourists coming to Thailand, it's hard for our population. I mean, for Thailand to to gain the loss, and the government, I think they have to balance between the health of the people and the economic, which is a big challenge right now because we're afraid of COVID-19 because we don't have a good therapeutic method, and also we still don't have vaccine. It's on the way, but we hope we will get the vaccine soon. But during this time, I think what we are doing is to promote the tourists within the country. I mean, promoting the Thai people to go out and start visiting the places to help the local economy. And also the government will have a campaign on Travel Together. So they are subsidize some amount of money for their people to register for being a part of the campaign. So the government will pay around 40% from your, to help payment for the rest you will pay from your pocket. So the government will help you with 40%. So then booking the hotel or spending, buying food or going to the restaurant. So that kind of category. So that will help some period of time. But later on, we have to think more if the pandemic is still going on, we still don't have the vaccine. Other things we have to come to consideration of the government. Thank you.
And would you share maybe some mitigation efforts for tourism specifically?
Yeah, so a lot of people lost their job because they're in the tourist system. So those people will switch their career. So some of them will become a good cooker. So then they're doing the business, online business, selling other thing like food or bakeries or some other that utility that necessary for the living. So and also in Thailand is an agricultural country. So most of the tourism there become more and more we call is based on the nature. So most of the people they are promoting the tourists for the nature. So then that will not affect much. But the number of the people that able to go out and spend their money, because that's the balance that people either saving the money because we don't know how long this is going to last. So so some of them losing their jobs already. So then they have to save their what they have right now. But for those who have more, so then we're promoting them to go out and spend more.
Great. Thank you so much.
Thank you.
We have one question from Bima John from Universitas Andalas Padang in Indonesia. So this question is for Dr. Thai from Vietnam. How did your governments handle the social challenges of implementing lockdown policies?
Actually, our country is locked down for only 23 days, not for too long.
Yeah.
That is a balance between the number of people in community got infection and the confidence of not having the community's transmission. But during that times, there is the question from the government to own people that if you want to be a hero, it's easy. Stay home, you can be a hero. And the other things that the most important is the whole countries understand the message from the government, and People keep staying home, and government provides food. Government provides some certain amount of money just to help the small business can keep working after the lockdown. And many different people who have more conditions than other share their own things. They build ATM for rice, not for money, for rice. So people who need food or rice, they can come and they can grab some rice and go and bring home and survive during that time. And the whole countries understand that. So I think that some a certain number of company have been closed, have been bankrupt. Yeah, that's a certain number. But for the whole countries, it survived. So I think that how the government work with COVID-19, and the most important is the support from people when they understand. If they not follow the government, the whole country will fail with the outbreak.
Yeah.
That's
Thank
more
you.
important.
Thank you. Yeah. I learned that behavior change takes time, and it is not easy at all. Not easy. So my next question is actually for all the panelists. What have you learned about how to educate and re-educate people that COVID-19 is a real threat? Sometimes it's hard to make people understand, let alone change their behavior, even our relatives. And this question is from Dr. Arif Wicaksono from Medical School, Universitas Tanjung Pura, Pontianak, Indonesia. Maybe Dr. Bakti, you can start.
Yeah. So I got asked this question recently, like, how does it feel when someone calls COVID-19 a hoax? My response is initially I have a grief reaction. I'm so angry, given that it almost took my husband away from me and my own life. And I go to the hospital every day and I see people die or people that have been on ventilators for 30 to 40 days. But then I also have this moment of realization where I understand it. This is so unimaginable, so terrible. Unless you've experienced it, you can't appreciate it. And also you yourselves are suffering the consequence of COVID-19 without seeing the consequence of COVID-19. So I think that public health professionals really need to bring a personal narrative to the COVID-19 pandemic. I think there was a media campaign about a week ago where people said on Facebook, curious, do you know one person who has COVID-19? And people respond saying, yes, this person I know, this person I know. And that raised a level of awareness that this is a real, actual threat. Yes, we can't see it, but it does affect our individual households and our communities. Yeah. So I think a personal narrative is what we need. We need to humanize our response.
Right. And so perhaps not just some rational explanation, but also, engaging the emotional side of the people. Thank you. Maybe Dr. Ron, do you have some comments?
So yeah, that's a good question. So I think we should consider the context of each country here. So to effectively change behaviors, of course, the technical stuff should be out there, but those messages should be communicated in a way that, first it has to be relatable, and then for example, in the Philippines, we have made big steps in terms of innovating, being very innovative with our social media campaigns. So we use all social media platforms to, and then of course, much of this is also working very well with the different expert groups. So when the national says this thing and that, of course, the science community, because of their very good track record and credibility, can help a lot. So like in the Philippines, we will often tap, for example, some famous celebrities. So so that they become champions. So sometimes people would identify with this figure. So so that also helps a bit, especially in our context. So making it a more personalized really is key in terms of doing it. And yeah, so but I think the foundation is really honest to goodness, transparent communication to build trust. And the biggest challenge is really how to communicate the biggest uncertainties as we still have up to now. So yeah, being very transparent and honest, and of course that should go well in terms of complementing strong government policies on this. So sometimes people don't believe the government when they're becoming too strict about it. So sometimes their behavior tends to be a little so I guess a mix of this strategy should be there, and it has to respond to the changing situation as well. So that's my take on it.
Thanks. Dr. Sharad Dao, do you have comments for that question?
Yeah, I agree with our panelists' comments on it, and I think that communication is the key. And like there's two sides of the COVID-19. One side we know, some of them, it's the virus, how it's transmit, and how it transmits. The transmission is kind of clear in some certain time that is a droplet, but later on there's saying that could be airborne. So then that's still mysterious about COVID-19, and to fight with something that you don't know them well. So then you be better to protect yourself against them rather than just rely and not follow the recommendation that put in place in a certain periods of time. That things changing over time, but just keep follows on that, and also like Dr. Long mentioned that building the trust between communicate with the public, the government communicate with the public, be honest with them, be transparent. So then you're building the trust, and then they will agree what recommendation that you're having for them.
Thanks. How about you, Dr. Thai? How about in Vietnam?
In Vietnam, the same thing happened with communication. But since we have SARS in 2003, people understand about this, and people still remember the story. Outbreak can come from our neighbor, China. And the thing we learned from China, I have already shown in TV quite early in January, or even late of December. We already know something had happened in China, something similar to SARS. People already aware from that, and we're waiting. Actually, we're really waiting for the incoming. And when it comes, a lot of campaign. Almost every day we talk about COVID-19. Almost every day people talk about COVID-19. It is conversation like everyday's conversation. Every day they talk about that, and everywhere, in a party, in a school, everywhere, people talking about that. So I think it's difficult at the beginning when we have to deal with fake news and other things. But after that, when people are fully understand the case, even people fully understand communications keep running on TV and other mass media and many different. And we also send experts to a different big group to share the story about COVID-19 and asking different university to join it, like the medical university, many different province also join the work, and they also do the training to many different level, and people understand by the direct talk like this.
Great, thank you. I have one more question for Dr. Thai. So this is a question from Febri in West Kalimantan, Indonesia. Do you use antibody rapid testing in Vietnam? Why or why not?
Actually, we did try that, and the test coming from Korea. But the things, very important things, is that cross reaction with other things, something like a normal corona or something like, we don't know. That turned out some positive, but have no contact, and we retest with real-time RT-PCR and other things. We find nothing from those people. So that we think that the antibody test is not good at that time. But it doesn't mean we're not doing that. we still develop our own rapid test using the positive reagent from Japan, and we have a project with Japan in order to develop our own test, and that one also really helped when we test the outbreak area to see that how many people have the antibody after the outbreak, after the community transmission. But only for that. We don't use antibody test so far for confirmed case. All confirmed case using real-time RT-PCR test.
Great. Thank you so much.
This is Bhakti. I just want to jump in quickly.
Please
The
do.
challenge with antibody tests fundamentally has become difficulty interpretation.
Yeah.
And so there's a caution that must be drawn that we do not really want people saying, well, I was positive on the antibody test, so I'm now immune. We don't really have clarity on how long antibodies last, what percentage of people develop antibodies, what antibody titers confer immunity or don't confer immunity, and how long it even takes for someone to develop antibodies post infection. So while there is like this public idea, like I want to know if I have antibodies because I want to know if I'm safe, and I get that. Interpretation of the antibody test still requires some significant understanding.
Great. Thanks for the addition. My next question is for Dr. Ron. This is from Redwan Firdaus in Indonesia. Does the Philippines have strict policy for people that don't wear masks?
Yeah. So wearing of mask is part of the minimum health standard. So as we are devolved, so our local government units, they have the flexibility to do their different ordinances. So some LGUs are kind of strict on it. So that's part of their regulations. Yeah. So, but yeah, there has been quite some challenges in terms of how it is being implemented in different local government units. But it is so much part of the health protocol. So the country is looking at the value now of universal wearing of masks as a cost-effective way to really do something about transmission.
Do you impose fine? Do you fine those who don't wear masks?
Yeah, so that is part of the regulations in some localities. Yeah, but it varies a lot. Yeah, so some will impose penalties, but some are just educating, but some are more proactive about it. So rather, aside from imposing this protocols, sometimes they make sure they provide the mask, especially for those who don't have the means. So it's a mix of different factors why people don't use the mask. So sometimes it's a matter of having the means to buy it. Sometimes they use it, reuse it, and sometimes, it's sometimes related to behavior as well. So there are many factors related to it, and different LGUs are implementing it differently. But that's part of the protocols for mask wearing.
Great. So the next one will be my last question. This is for Dr. Bhakti. Is Dr. Bhakti still here? She's not here. Okay. Perhaps the last question goes to Dr. Sharat Tao. What are your recommendations on best practices for government transparency?
That's a very and very hard to answer.
Just go on.
Yeah, I think best practices would be right, be the first. Don't let the public or the media to go panic when you know something, and then you're come later from the media. That's not gonna help the situation. So you have to be the first on everything. Even you know or you don't know, you have to tell the public that. If you know, you tell them. If you don't know, you just let them know that this is still waiting on the lab result or something, or we're still under investigation on the investigation of the cases. Don't let them wait and find out from the social media, because currently social media is very, very fast, and fake news and wrong information can go quickly. So you have to keep up with all this technology, and also all kinds of media that you have in here. So you have to be the first in everything, and telling the right information, not trying to hide anything, not trying to be suspicious. I think that would be my recommendation.
Great. Thank you so much, Dr. Sharat Rao. And once again, thank you so much for all of our speakers tonight. Now we have come to the end of this webinar, and I have some take-home points from our conversation. So I would say the key success, some keys to Southeast Asia successes in dealing with the pandemic is, first, rapid response, like in Vietnam. And second is evidence-based and science-informed leadership. And three is clear and transparent communication from policymakers down to the grassroots level. And fourth, clear communication and personal narrative is also very, very important in engaging people for behavioral change. So this pandemic makes us realize that we are all interconnected. We cannot defeat this pandemic on our own. And remember, our global health security is only as strong as our weakest link. So let us continue to learn and support each other in fighting this ongoing COVID-19 pandemic. And just as a reminder, if you would like to continue the conversation with other professionals in Southeast Asia and other developing countries, please fill the Google form. You can find the link on the comment section, or you can type bit.ly/US ASEAN Health Future. And again, I would like to thank our speakers, Dr. Thai, Dr. Ron, Dr. Sharat Rao, and Dr. Bhakti for the very insightful presentations and discussion. I would like also to thank our audience for listening and participating, and for your great questions. I learned a lot tonight. I hope you also learned something tonight. So see you again next time. Thank you. And back to you, Jasmine.
Thank you.
Okay. Thank you so much, Dr. Monica, for moderating tonight. So earlier in the event, we asked you guys, which Southeast Asian country has not recorded a single fatality from COVID-19 pandemic? And the correct answer is Vietnam. Though the country borders China and has a population of 97 million people, there are only 300 cases of COVID with no fatalities recorded. And unfortunately, no one got the answer correctly tonight, but maybe next time, you guys can join in our quiz. So for those of you who may be wondering, how can you develop an awesome idea at an awesome place like AdAmerica? It's really easy. You can just go to our website at www.adamerica.or.id, select create a program, and go to collaborate with us. All proposals coming to us will be reviewed, and your event might be featured here soon. So this wraps tonight's event. I'm so sorry we have to say goodbye, but hopefully we'll see you again at the next AdAmerica TV event. Don't forget to subscribe to our YouTube channel at AT America. And also follow us on our social media on Instagram, Facebook, and Twitter. I'm Jasmine signing out. Have a great night, everybody. Bye-bye.